going over aquatic exercise. So I love aquatic therapy partially because I just love the water, but also because I found that you can do so much more with patients in the water because of the relaxation properties of water, the ability to decrease weight bearing in water, decrease in muscle tone. And so there's a lot of benefits to aquatic therapy that make it an exciting tool to use. Is using the benefit of water properties to help patient heal. And a lot of those benefits are the things that I just listed off, and we're going to talk about those a little bit more in depth throughout this lecture. Any intervention, we want to have a point and purpose to what we're doing. So what are our goals of aquatic exercise? We use aquatic therapy to facilitate range of motion exercises, to initiate resistance training, to facilitate weight-bearing activities, to facilitate cardiovascular exercise, enhance delivery of manual therapy techniques, provide 3D access to the patient and 3 dimensions of resistance to the patient's movements, initiate functional activity replication, minimize risk of injury during rehabilitation, and enhance patient relaxation. So all of these things are reasons why we would want to utilize aquatic therapy with a patient. Those goals sound awesome, and it would be great to jump into aquatic therapy with every patient that we treat. But we do have to consider precautions and contraindications to aquatic exercise. So we'll start here with the precautions. Fear of the water is going to be a very big one. If a patient has a natural fear of the water, they're less likely to relax, they're less likely to be able to concentrate and focus on the movements that they're supposed to be making, regardless of the depth. And so unless we can overcome that fear, we don't want to put them in the water. So this is just going to be a precaution. We're going to stop, we're going to think about it, we're going to see if we can address it before we initiate that intervention. Neurological disorders are going to be another precaution to consider. Patients may have difficulty controlling movements, and they may be heat intolerant, such as patients with MS and post-polio disorder. Those patients are going to be really heat sensitive, and so warmer water temperatures are going to be difficult for them to tolerate because it's going to increase the body temperature faster. Water conducts temperature 25 times faster than air, so warm water is going to make a person hotter faster than warm air is. And so we need to be sensitive to those patient populations with neurological disorders, but also then looking at their ability to control movement and whether or not they're safe to put into the water. Respiratory disorders. So hydrostatic pressure of the water may make lung expansion more difficult, as well as the increased return of circulation to the chest that occurs in the water. We have pressure pushing on the body from all directions from the water. And that's going to increase venous return to the heart, and that can potentially increase blood pressure. And so somebody with respiratory disorders is then going to have difficulty expanding the chest because they're pushing it out against the hydrostatic pressure, and they're dealing with the increased cardiac return that's limiting the amount of space that the lungs can expand. And so we want to stop and consider whether or not aquatic therapy is appropriate for this group before we put them in the water and make sure that they can tolerate it. If they have cardiac dysfunction, we're looking at some of the same kind of considerations as our respiratory disorders. But symptoms that we can look for are going to be angina, abnormal blood pressure, heart disease, compromised cardiac pump mechanisms. These all require close monitoring in aquatic environments. So we want to make sure that we're checking their vitals beforehand so that we have a baseline. If they demonstrate any kind of decompensation, we want to be able to follow up, check vitals. If they report pain, we want to ask further questions into what that pain is. If it's anginal pain or chest pain, then we may terminate treatment. If it's a orthopedic pain, we can figure out what to do from there. But we want to take special precaution with our cardiac patients in the pool or in the water. And then patients with small open wounds or lines. Small open wounds or lines may be covered with a waterproof or occlusive dressing and can be okay in the pool, but you have to keep an eye on it because there's risk for an infection because that's an opening to the body, right? And so bacteria can accumulate in the water and it can get into the body through that open wound. And so we need to have occlusive dressings on them and paying attention to how they respond if there's any signs of infection. To aquatics, these are going to be our patients that we are absolutely not putting in the water, that this is not going to be a good intervention for them. So these are going to be patients with incipient cardiac failure and unstable angina, respiratory dysfunction with vital capacity less than 1 liter, so they have severe respiratory dysfunction, severe peripheral vascular disease, danger of bleeding or hemorrhage, severe kidney disease because these patients are unable to adjust to fluid loss during immersion in the water. The hydrostatic pressure influences the changes in body and kidney function. Open wounds without an occlusive dressing, so just big open wounds with nothing waterproof protecting them. Skin infections such as ringworm. Uncontrolled bowel and bladder, so our patients who are incontinent and do not have a bowel and bladder program that they use to regularly empty. Menstruation without protection, water and airborne infections like flu, GI viruses, typhoid, cholera, polio, those are all going to travel easier, faster, and farther in the water. And so we don't want to put those patients in the water because we don't want to infect other people. And uncontrolled seizures during the last year, we don't want a patient having a seizure in the pool. That would very much so be unsafe. Time for your first question. A physical therapist assistant is preparing a patient with a history of congestive heart failure for aquatic therapy. Which of the following actions is most appropriate prior to initiating treatment? A. Begin aerobic training in 33 degrees centigrade water. B. Closely monitor for signs of cardiac decompensation. C. Perform underwater stretching in deep water without flotation. D. Start exercises in water colder than 22 degrees. Pause now to think and read. B. Closely monitor for signs of cardiac decompensation. Hopefully you were able to eliminate the two answer choices with the temperature involved in them, considering that we have yet to go over the temperature considerations. But the other reasons why B is the best answer is the patients with cardiac dysfunctions such as CHF require careful monitoring during aquatic therapy due to the increased cardiovascular demands caused by immersion. The hydrostatic pressure increases venous return and may exacerbate symptoms of cardiac decompensation. High temperature water or vigorous activity can increase cardiac output demands, potentially putting the patient at risk. Therefore, monitoring is the safest and most appropriate first step. Back into the lecture, let's talk about the properties of water. So we have four main properties of water that we're going to discuss here and how they interact with how we can influence patient treatments in aquatic therapy. And so those are going to be buoyancy, hydrostatic pressure, viscosity, and surface tension. Buoyancy. Buoyancy is the upward force that works opposite to gravity. So buoyancy points up while gravity points down. The clinical significance of buoyancy is that it allows the patient to feel like they weigh less in the water, and it helps to unload the forces on weight-bearing joints. It may also change the function of muscles when the force of buoyancy is what the patient needs to control against as opposed to the force of gravity. This is something that I want you guys to consider playing around with when you're in the pool. How does your muscle action change when you put a flotation device on your ankle versus when you have something like a weight on your ankle? When are we using more of our muscle actions that are similar to on land versus what are we having the opposite eccentric control contractions happening because of buoyancy? The amount of air that you have in your lungs affects buoyancy. When trying to float on your back, if you take a deep breath, you float better. If you blow all of the air out of your lungs, you sink a little bit. Body composition also affects buoyancy because fat floats, and the placement of buoyancy devices will move the center of buoyancy towards the device and displace the body in the opposite direction. So if I have a flotation device on the anterior side of the trunk, it's going to displace the body posteriorly. If I have a flotation device on the posterior side of the trunk, it's going to displace the body anteriorly because it's moved my center of buoyancy towards that flotation device, and the center of buoyancy always wants to go to the top. So if we think of buoyancy as the force that opposes gravity, we know that gravity points down, so buoyancy points up in the water. And the point of buoyancy as far as patients go is that buoyancy in going in the opposite direction of gravity helps us to de-weight when we're in the water. So if I'm standing on dry land, I have 100% of my body weight because gravity is pushing down with no opposition from buoyancy. If I wade into about waist level or level of my PSIS, I have about 50% body weight because the buoyancy is opposing the force of gravity, decreasing the amount of body weight that I'm experiencing. If I wade in all the way to neck level, then I'm at, or C7, then I have about 10% of my body weight because again, gravity is opposing the force of buoyancy, or I'm sorry, buoyancy is opposing the force of gravity, decreasing the body weight that the patient is experiencing. So if we look at my three stick men here, we can look at how flotation devices can alter center of buoyancy and affect our treatment. So this guy with no flotation device, if I put him in, he's gonna sink and then eventually float to where he's level on the surface. This guy with my flotation device all the way around him is going to resist sinking. See if I can do it around the side. Resist sinking. I have to push down more and I can feel that force of buoyancy because of his flotation device. And then he's gonna end up floating in whichever direction his center of buoyancy feels most comfortable because that flotation device is all the way around. But if you can see here, bring this guy out of the way. Because that flotation device is more up towards this flat end, the rounded end of the stick is more in the water. Compare that to our last guy here, whose flotation device is only on the front. When I push him down, I don't have as much resistance to pushing down because the buoyancy is only being increased on the anterior side. But when I let go, he's always going to flip onto his back side because the center of buoyancy is now going to shift anterior, causing the body to distribute this way. It's also important to pay attention to that these sticks float because they are less dense objects. But this penny that weighs the exact same amount as these sticks sinks because dense objects sink despite the buoyancy. A little visual to break down the percentage of body weight at various immersion depths in case my little stick figures weren't good enough for you. So we're going to be at about 50% body weight when the water level is at the ASIS, 33% body weight when water level is at the xiphoid process, and 10% body weight when the water level is at the C7 vertebra. I know that we're in Oklahoma, so there probably aren't a whole lot of scuba divers, but if you've ever swam down to the bottom of like a 10-foot pool and you felt that pressure on your ears, that's the result of hydrostatic pressure. And so water exerts hydrostatic pressure from all dimensions on whatever objects are immersed in it, and that includes the body. So hydrostatic pressure is the pressure exerted by water on the immersed object. The clinical significance of this is that when a patient is in water, it helps to limit swelling or effusion and helps to assist venous return. It helps to induce bradycardia because the hydrostatic pressure is helping return more blood to the heart. The heart doesn't have to pump as fast. And it centralizes peripheral blood flow. And it also can help to return to the trunk and chest more effectively. So hydrostatic pressure can be a benefit to us in a clinical setting, especially when we have patients with edema and we need to improve circulation and return to the heart. But it can also be a downfall in patients where there's limitations as a result of that hydrostatic pressure. So it can adversely impact patients with cardiac and pulmonary conditions as a result of the increased work of breathing. Or remember, in cardiac dysfunction, that increased venous return to the heart can overload the heart and cause cardiac dysfunction as well. The hydrostatic pressure increases with the depth of the water, so exercises are more easily performed close to the water's surface. The deeper we go, the more pressure that's being exerted, and so the more force that's needed to push through that hydrostatic pressure. We don't typically do a whole lot of aquatic therapy at deep levels because of not wanting to immerse our patients' heads below water, and so we don't typically experience tremendous adverse effects like that pressure on your ear when you dive down to that deep part of the pool. But it is important to remember that when you're in a deeper part of the water, your body is having to work harder. For the concept of hydrostatic pressure, we can experience this by putting our hand into a bowl of water and feeling the pressure of the water around us. This serves as a compressive agent for patients in aquatic therapy, and so it can be great for patients with edema, but in patients with cardiac or pulmonary dysfunction, it can increase the difficulty of breathing. The deeper in the water a patient goes, the more hydrostatic pressure they're feeling from that water around them, and the harder breathing can become. It also increases the difficulty of tasks. We can also see hydrostatic pressure by putting this bag in, so you can see the air is pushing out against the bag, but as I push it in through here, the water starts to push in on the bag more than the air is pushing it out onto the bag. And that shows you the increased hydrostatic pressure of water compared to air. Viscosity is a fluid's resistance to flow, and it results due to the friction that occurs between the molecules of the liquid. And so when there's more friction between the molecules because the liquid is thicker or more viscous, then it flows slower. And so viscosity describes how well a fluid flows. Blood is 6 times more viscous than water. And so if that gives you kind of an indication of when you watch water drip versus when you watch blood drip from something, there's that thicker viscosity to it. There's a greater resistance to flow with blood than there is compared to water. Clinically, this matters because viscosity creates resistance with all active movements within the water, because that resistance to flow as you are moving through it, the water is providing a viscosity resistance. You can increase the resistance to a movement by increasing the velocity or the speed of the movement. So if we can do walking versus jogging in the water, we can do faster movements versus slower movements, whether that's upper extremity exercises, lower extremity exercises. We still want to make sure that we're prioritizing control in the performance of faster exercises in the water, but there is a greater challenge that's being provided with increased speed compared to land training. Increasing the surface area moving through the water increases the resistance. So for example, it's harder to move your arm through the water if you have a paddle than just your hand by itself, because the viscosity of the liquid is having more surface area of something to come in contact with, which produces more drag and therefore greater resistance. Viscosity is a concept that's hard to see unless we use different liquids. But if I stir this air, I have no resistance because gases have less viscosity than liquids. If I stir the water, I can see the resistance and the turbulence that it creates. I can't see that turbulence in air the same way unless there's large amounts of that drag being generated. Versus if I try to stir this honey, I experience a lot of resistance. There's not as much turbulence that develops because the viscosity of the honey makes it difficult for me to stir. Surface tension is the property of water that results due to the fragile adhesion of molecules due to their attraction to one another. And that's the property that allows fluids to hold a drop formation, is that surface tension helps to maintain that droplet form. Surface tension is the surface of a fluid acts as a membrane under tension, and so it creates this barrier that has to be broken. Clinically, this matters to us because exercises that require the patient to break the surface of the water repeatedly have increased resistance and therefore increases the difficulty of the exercise. If we're having to go up and down through the surface of the water, we're having to break that surface tension, which requires a certain amount of force in order to push those molecules apart. And granted, it's not a substantial amount of force, but it is a way that we can increase the force resistance in aquatic therapy. An extremity that moves through the surface performs more work than if kept under the water, and using equipment at the surface of the water helps to increase the resistance. So again, like those paddles and things that we'll talk about going forward in this lecture. Surface tension exists because of water molecules adhesion to one another. So if I sprinkle this pepper into this bowl, and hopefully you can see it, you can see, I might need a lot more than that so you just can see it. You can see how most of it floats, right? That's because of the surface tension of the water. I can make the pepper sink by breaking that surface tension in various spots. Surface tension requires force to break, and so anytime a patient has to use an exercise that goes and breaks the surface tension of the water and comes above and below it, they're creating more force, and so it makes the exercise harder for the patient to complete. This might be a better angle to see how the pepper sinks, but as I break the surface tension, the water is no longer holding the pepper up, and you can see how it falls to the bottom. Hydromechanics, so we're really talking about the way that fluids move, right? And we've got three factors that affect the flow of water. A laminar flow is going to be movement in which all of the molecules are moving parallel to each other in a typically slow movement. And you can think of this like a slow flowing creek or river where the water is just gently streaming and everything is moving in the same direction. Turbulent flow is going to be movement in which molecules do not move parallel to each other, and typically faster movements. So you can think about this in the areas where we've got rocks and you've got rapids that are created, and we have different directions of water flow as it goes around these obstacles. It creates greater turbulence within the water, and that's our turbulent flow. And then our last factor here is going to be drag, and that's the cumulative effect of turbulence and fluid viscosity acting on an object in motion. So drag isn't a property of water because it doesn't stand alone by itself the way that viscosity does, but drag is influenced by both viscosity and the turbulence of the flow of the water. And so if we have decreased turbulence, we have decreased drag. And that's important for clinical understanding because if we want to increase the difficulty of a task, we want to increase the turbulence that the patient is experiencing within the water, because we're not going to increase the viscosity of the water, right? The water, its viscosity as a property in and of itself helps to promote this drag for resistance, but we can't affect viscosity. We can affect turbulence. And so we can think of this in terms of like jets within pools where we're creating streams of movement in different directions. That's going to increase the challenge for an exercise for a patient. So the property of drag tells us that it takes more force to move faster in water, right? I can stir this a certain amount with that amount of force that I can generate from my knife, or my battery operated frother creates a greater amount of turbulence because more force creates faster movements. And so faster movements are going to be harder to do in water. The other property of drag that we can consider is surface area. So with this amount of drag, I don't create as much turbulence with my popsicle stick going in sideways. But if I put it in perpendicular to the resistance, put it over on this side, I get more turbulence as it goes this way compared to this way. All right, question time. A PTA is treating a patient with poor lower extremity motor control in a therapeutic pool. The assistant instructs the patient to perform stepping exercises at mid-chest level. Which property of water provides the greatest benefit for this activity? A, surface tension, B, buoyancy, C, viscosity, D, hydromechanics. Pause now to read and think. Pat on the back if you went with B for buoyancy. Buoyancy reduces the effects of gravity, decreasing joint load and providing support to patients with weakness or motor control issues. Immersion to mid-chest level reduces body weight bearing to about 25 to 35%. We're looking at that xiphoid process being 33%. And since we don't have a specific anatomical level here, we know it's a range of 25 to 35%, allowing the patient to practice movement safely. This makes buoyancy the most beneficial property for the described activity. Let's talk water temperatures. So if you remember earlier, I said that water conducts temperature 25 times faster than air. So this means that temperature or patients can have greater impacts from the temperature at faster rates. And so we need to be mindful of some specific considerations so that we make sure that we maintain patient safety and also make sure that we try to appropriately select the best water temperature for our patient population. Patients can't maintain core warmth at water temperatures less than 25 degrees Celsius. At water temperatures greater than 37 degrees Celsius, prolonged or intense exercise may be harmful as immersion causes increased cardiovascular demands. So we need to make sure that if we're in warmer water temperatures, we have shorter duration activities. With immersion, there's less skin exposed to air, resulting in less opportunity to dissipate heat through normal sweating. And so with that, we see that patients have the increased ability to overheat if they do not have the appropriate temperature water. Water conducts temperature 25 times faster than air and more if the patient is moving through the water quickly. Patients perceive small changes in water temperature more than they do small changes in air temperature. Over time, water temperature may penetrate to deeper tissues, causing whole body cooling. And at temperatures greater than 37 degrees Celsius, cardiac output increases significantly at rest. And so we need to be mindful of patients' cardiac abilities and cardiac strain or stress when even they are just resting for stretching activities in a heated pool. Temperature guidelines, just some general rules to follow when selecting the appropriate water temperature for your patient to implement aquatic therapy. 26 degrees to 35 degrees Celsius is used for aquatic flexibility, strengthening, gait training, and relaxation exercises. This is going to be the temperature range of most therapeutic pools. The cooler end of that range, so our 26 degrees to 28 degrees Celsius, is used for cardiovascular and aerobic exercises because remember, at higher temperatures, we have increased strain on the heart. 33 degrees Celsius, warm water is beneficial for patients with acute painful musculoskeletal injuries such as osteoarthritis because it promotes relaxation, elevated pain threshold, and decreased muscle spasm. And I want to make sure that I clear up any potential confusion there when I list osteoarthritis. I'm talking about acute exacerbations, not necessarily the chronic condition, because yes, I am talking about acute conditions here. And so acute exacerbations in osteoarthritis or new onset musculoskeletal injuries that are non-traumatic so that we don't have any open wounds or at least closed traumatic if that needs to be the case, but they benefit from warmer water temperatures. 22 degrees to 26 degree cool water should be used for intense aerobic training above 80% of patients' maximum heart rate to minimize the risk of heat illness. And we're typically only going to use temperatures this low in our more athletic population that we're trying to really push the training in. Warmer water temperatures are recommended for patients with rheumatoid arthritis, except in the acute stage, because that will help increase the inflammatory response that they are experiencing. Lower temperatures are recommended for patients with spasticity or when immersion times last more than 20 to 45 minutes to help prevent overheating of the body with prolonged immersion in warmer temperatures. It is very important to note that patients with MS should never be exercised in a heated pool due to the increased risk of heat-related fatigue in this patient population. Post-polio syndrome is another patient population that would be impacted by this, but we have a lower prevalence of post-polio, and so I would make MS a population of note. How long should we be in the water for with our patients? So our immersion times and kind of general rules to use here. Generally use a maximum immersion time of 20 minutes for patients with non-compromised cardiopulmonary systems. Begin with 10-minute treatment sessions and increased time is tolerated. I can say that starting with 10 minutes is a good idea to get patients very comfortable and used to it. Increasing to 20 minutes is, again, good to build tolerance, but if we can limit having to make only part of a treatment session aquatic therapy and be able to make our whole treatment session aquatic therapy based, then we usually have better utilization of our resources. There are clinics with aquatic therapy tanks in clinic, and so there's the ability to transition between both, but sometimes that's difficult for patients with the whole drying off, changing process and all of that, and how that influences your scheduling and billable time. The other side of that is that not all clinics have access to a therapy pool, and so when they do offer aquatic therapy, it's at a different facility, and so that is a scheduling thing that you have to be able to manage within your schedule demands and can influence, again, what your billables are and all of that stuff. And so these are good guidelines for getting patients started and considering safety, but clinically, we're probably working up more towards trying to do a whole treatment session if we're utilizing aquatic therapy. Always monitor vital signs to ensure patient safety, and lower water temperatures are recommended for immersion times greater than 20 minutes. Knowledge check time. Which of the following patients is most appropriate for aerobic aquatic exercise in water maintained at 27 degrees Celsius? A patient with acute rheumatoid arthritis. B, a patient with severe spasticity. C, a patient training at 85% of their maximum heart rate. D, a patient with acute low back pain. Knowledge check time. Hopefully you paused to read and think on your own since I forgot to cue you to do that. But if you did not, here we are. The answer is C, a patient training at 85% of their maximum heart rate. Cooler water temperatures, so that 22 to 26 degrees Celsius, is recommended for patients participating in intense aerobic activity to reduce the risk of overheating. 27 degrees falls within a safe range for cardiovascular conditioning. Patients with acute RA or severe spasticity typically require warmer water to prevent symptom exacerbation, and so these answer choices would have been able to be ruled out pretty easily. Obviously, we're going to need a pool if we're doing aquatic therapy. And so we can look at traditional pools or the individual patient pools. Most clinics are going to have more of an individual patient pool, whereas if they have an off facility location that they utilize, that's more going to be where you can see a traditional pool. Traditional pools are going to measure up to 100 feet by 25 feet if we're looking at our standard Olympic size, with depths ranging from 3 to 4 feet to 9 to 10 feet. Entrances to these pools can include ramps, stairs, ladders, and patient lifts. And so this is a point of consideration for whatever therapy pool you're using is there a way for your patient to get in safely and get out safely? And the biggest benefit of these traditional pools is that we can do group therapy because there's enough space for multiple people to be moving around in there. Individual patient pools are designed for one patient at a time. Their entrances are usually via a door or 2 steps to the side of the unit. They can be as small as like the footprint of a treadmill, where it's literally just a tank that they step into and the patient, it then fills up with water and the patient can work in it. Or they can be larger tanks that can sit above ground and give you, depths up to 6 to 8 feet, depending on what the clinic space can accommodate. What is nice about the individual pools is those typically have the different accessories you can add, like the jets or the treadmill in the bottom, where you can increase the resistance by changing the turbulence that the patient is experiencing to increase that drag. You can create more closed chain and continuous movements with use of a treadmill. And so there's a lot more ways to manipulate the variables in individual patient pools. But again, traditional pools are more cost effective, easily accessible, and you can do group therapy in them. Equipment that we can use inside the pool can include our flotation devices like a cervical collar, which you can see in that top picture, which is used to support the head and neck in the supine position and maintain the head out of water. We also see flotation rings in that bottom picture. They come in various sizes and they're used to support the extremities and provide buoyancy. They can also create a different direction of resistance when used on the extremities for exercises. Buoyancy belts are used around the waist or extremities to help patients float, especially like in performing deeper water aerobic conditioning, where we need to be able to move freely without touching the ground while also needing to stay above water and not drown. Dumbbells come in short or long lengths, and they can be used for flotation or strengthening. A lot of times we can use dumbbells for support of upper or lower extremities while performing an exercise of the other. They also increase the buoyancy because they are a flotation device, and so they can alter the muscle activation depending on how we utilize those flotation dumbbells in the water. Paddles and fins can be worn on the hands and feet to increase resistance in the water. We use paddles and gloves to offer resistance to the upper extremities, and fins and hydrotone boots to provide resistance to the lower extremities. Kickboards can act as flotation devices, so we can have patients float on them for support and stability for different exercises or activities that we need. We can also use them to provide increased resistance for like whole body movements through the water. So similarly to how paddles can create resistance for the upper extremities, we can utilize a kickboard while walking through the water to increase the resistance by increasing that drag. We can also provide a balance challenge by having patients attempt to sit, stand, kneel on a semi-submerged kickboard and maintain their balance in an upright trunk. And so kickboards have a lot of applications within aquatic therapy. Pool care and safety. So obviously we have good reason to be clean and safe around water-based surfaces. So we want to clean regularly, twice weekly at a minimum, and test chlorine and pH levels twice a day. Non-slip surfaces should be applied around the pool with dry splashes regularly. There should be safety rules and regulations posted, and life preservers should be readily available, and staff should be CPR trained and present at all times. Benefits of aquatic stretching are going to include an increased ease in positioning patients, warming of soft tissues for increased extensibility, and relaxation of patients to allow for more passive movement. This picture demonstrates manual stretching of the cervical spine. So you can see the patient has a buoyancy belt on to help them float in a supine position as the therapist takes the cervical spine, moving the head to stretch the cervical spine. Using a cervical collar flotation device and the buoyancy devices at the ankles to help support the lower extremities and keep the patient floating in supine, we can also manipulate the trunk to enhance manual stretching into lateral flexion. Shoulder stretches would be the same for what we've learned on land, but we have the patient donning a cervical flotation device and a buoyancy belt so that they can relax and supine in the water, allowing for the properties of the water to increase relaxation and provide a better stretch. Hip and knee stretches can be easier to perform in the water because we're able to submerge the patient's leg below the surface of the water, whereas on land the table would get in the way. Flotation devices can be used on patients' extremities while they immerse the trunk in the body to allow the flotation device to elevate the extremity and provide a self-stretch. Upper extremity manual resistance exercises can be performed the same way that they can be performed on land, just with the patient having the appropriate flotation devices on and the therapist applying resistance through all planes of movement that the patient requires strengthening. These are just a couple more pictures of upper extremity manual resistance exercises to demonstrate the directions that the therapist can apply resistance. We can do the same thing for lower extremity manual resistance exercises, applying resistance in a single plane of movement or reversing planes of movement depending on what it is we need to target for the patient, utilizing flotation devices to maintain a supine position, but we can also try seating a patient on a kickboard and trying to attempt manual resistance exercises for the lower extremity in that position as well. We can perform trunk stabilization exercises in the water by having a patient attempt to maintain a stable trunk while we provide this kind of serpentine motion to them using their upper extremities to try to sway their body, their trunk back and forth in the water, and the patient has to try to combat that perturbation style motion and maintain a neutral position in the water. Most exercises that we perform on land can be implemented in the pool. Use of paddles creates resistance in both directions for concentric contractions of muscle groups on both sides of the joint. So if we look at picture A there, use of the paddle would provide a resistance for both internal and external rotation, having a concentric contraction in each direction and no eccentric contraction in this portion. For lower extremities, we can use paddles or the fins or the hydrotone boots to create the same thing. And we can use buoyancy devices on upper and lower extremity devices or upper and lower extremities in order to change the direction of resistance. So remember, buoyancy is going to push up, whereas muscles are used to resisting gravity, which pushes down. And so the use of those buoyancy devices requires more eccentric control against the buoyancy and alters muscle function in the water. Table 9.2 in your textbook creates a summary of lumbar rehab exercises. I'm not going to read through these for you. You guys can take a look at them on your own. But essentially, it gives you an idea of different activities that you can implement with your patients in the water should you be starting an aquatic therapy treatment and not know where to start. Aquatic therapy is also great for aerobic conditioning. We can do mid-water jogging or running in a standard pool, or if we have those individual therapy tanks with an immersed treadmill, we can utilize those. There's deep water walking or running that's going to change the challenge based on hydrostatic pressure and increased resistance. We can have a patient simply work on swimming strokes to build that aerobic conditioning and overall activity endurance. Deep water walking, running, patients without cardiovascular compromise may experience dampened elevation of heart rate, ventilation, and VO2 max compared to land-based exercise. So we might not see the same peaks in the water as we do on land, which can be safer for some patients. During low-intensity exercises, cardiac patients may experience lower cardiovascular stresses. VO2 max gains during aquatic conditioning carry over to land conditioning. So we may not see the same increase in the water as we do on land, but gains that we make in the water will carry over to the land. It's time for another question. A PTA plans to perform deep water aerobic exercises with a patient who has difficulty maintaining upright posture. Which piece of equipment is most appropriate to ensure patient safety and independence during this activity? A. Kickboard, B. Hydrotone boots, C. Buoyancy belt, D. Hand paddles. Pause now to read and think. And the answer is C. Buoyancy belt. A buoyancy belt helps keep a patient afloat in an upright position during deep water activities. It provides safety and support, especially for patients with postural control issues. Kickboards are better for upper extremity support in shallow water, and resistance devices like hydrotone boots or hand paddles may be inappropriate for patients with instability. Alright guys, that's all I have for you on aquatic therapy. I believe that your lecture that is posted in the PowerPoint version has some embedded videos that gives you some examples of aquatic intervention should you want to take a look at those for some supplemental information. Before class, I want you to remember to write down any questions you had from this lecture and bring them to class to discuss. We can't do anything with our questions if we don't remember to ask them, and we can't remember to ask them if we don't remember what they are, so please write them down. And play around with the properties of water and consider how you can manipulate them during your aquatic aerobics activity so that you can really understand these concepts.